Good morning. My name is Amanda Zylak, and I'm here to do a transfusion medicine educational session for Weyburn and Estevan. Always, we just want to remind everyone of SHA's vision, mission, values, and philosophy of care. We acknowledge that we are gathering on treaties 2, 4, 5, 6, 8, and 10, the territories of and the homeland of the Dakota, Lakota, and Métis people. Transfusion safety and patient blood management. Who are we? My name is Amanda Zylak. I am new to this role as of September. Prior to this, I was an MLT in transfusion medicine for 14 years. I have a counterpart in the north named Kimberly Goodwill, and we work very closely together to support the whole province. So if I'm ever unavailable, please call her or Jennifer Lambert. I will give you their contact information at the end. Jennifer Lambert runs the Regina Transfusion Medicine Department. Her staff do all the complex transfusion testing for southern Saskatchewan, and they send compatible blood to the rurals. Kim and my roles as the transfusion safety managers for the province is to support all of you and promote safe, effective, and standardized transfusion practices across the province. This has been neglected for far too long, as we all know, and we are working on making our processes better and safer for our patients across the province. So there's a big push in the transfusions world right now called patient blood management, and it is an evidence-based multidisciplinary approach to optimizing the care of patients who might need a blood transfusion. It focuses on improving outcomes by optimizing the patient's own red cells, such as treating anemia before surgery, minimizing blood loss and bleeding through surgical anesthetic and laboratory best practices, and finding patients' true hemoglobin thresholds, so only transfusing when absolutely required. The goal of PBM is to ensure that patients receive the right care at the right time with the least amount of exposure to donor blood, thereby improving safety, conserving resources, and reducing cost. Part of our portfolio is also the IG Stewardship Program. This program monitors and ensures the appropriate use of IVIG. IVIG is $67 per gram, and some patients are on doses as high as 200 grams. Some patients will be on IG for their lifetime, so it's the job of the IG program to taper patients' doses to the lowest possible dose that actually works for that patient. So transfusion safety. In Canada, every part of the laboratory is regulated by Health Canada, and that's especially true in transfusion services and the blood products we manage. Because of these regulations, we are required to maintain a vein-to-vein traceability. In simple terms, that means that we must be able to trace back every blood product or component from the donor all the way to the patient, including every step in between. So storage, transport, modification, and final infusion. Hospitals must keep permanent records of which blood products were issued to which patient and when. These records are kept indefinitely to meet national safety and traceability requirements. All of our labs are accredited by the WCAA, with the exception of Regina, who holds CAP accreditation, which means that they are even more rigorous standards applied there. None of the rules we're going to talk about today are arbitrary. They're all based on national and international standards designed to ensure that every patient receiving transfusion gets the safest possible product. So all blood components are manufactured by Canadian Blood Services and collected by volunteer donations. So blood components are separated parts of the whole blood. So they include red blood cells, platelets, plasma, and cryoprecipitate. Blood products are mostly purchased by CBS from vendors. So blood products are made by fractionating plasma proteins. They include things like albumin, IVIG, fibrinogen concentrate, and coagulation factors. So blood component basics. So the whole blood donation can be broken down into three main components: packed cells, plasma, and platelets. So there's another component called cryoprecipitate, but Canadian Blood Services can only make cryoprecipitate or platelets. So platelets are so much more useful, especially when there is a product called fibrinogen concentrate that works the same, if not better, and it's a safer product. So most places are very much moving away from cryoprecipitate and just using fibrinogen concentrate. A typical red blood cell unit issued by Canadian Blood Services is approximately 287 mils. 1 unit of red blood cells usually increases the hemoglobin by approximately 10 grams per liter in a 70 kg non-bleeding adult. Blood samples collected from the donor at the time of donation are tested against certain transfusion transmissible infectious agents. A big topic lately is vaccines. CBS does not make their donors disclose if they have been vaccinated. So if a client does not want vaccinated blood, there is actually no way of finding out that information. Red blood cells are stored at 1 to 6 degrees. So Moosland and Kipling, you guys don't store plasma or platelets, so this is going to just be for your awareness. Plasma has mostly been replaced in the province by a product called Octaplasma. It is produced by Octapharma. It is plasma, but it is more processed, so we get the same benefits of plasma, but it is a safer product. So platelets, pooled Sorlin treated, so they are pooled from multiple donors of the same blood group, and apheresis Sorlin treated platelets are produced from single donor apheresis platelet donations. Each dose of platelets should increase a patient's platelet count at 1 hour by an increment of 15 in a 70 kg adult. Some disease states can decrease the amount of an increment, such as sepsis or fever. Platelets are stored at 20 to 24 degrees. All blood products and components must be visually inspected upon receipt, at the time of issue, and at the time of infusion. CBS's visual inspection tool is an educational resource meant to inform the user about the visual variability of blood components and its causes. So the link is right there, and it takes you right to the Canadian Blood Services website. The picture on the slide shows the variation of color between 2 normal packed red blood cells. So here are some problems, examples of problems that for red blood cells. So the first example, there's a clot. The second example is bacterial contamination. So the unit will look completely black. The third, there's some cellular aggregates in there, and then white particulate matter and hemolysis. So if any of these things are seen in a unit, do not transfuse it, call Canadian Blood Services, send it back to the lab. It needs to be documented. Fractionation products such as albumin or IgG, the product should not be cloudy, the lot number should be legible, and the safety seal should be intact. This is just an overview of what a CBS label looks like, and most important for nursing to know is about the donation number is at the top corner and the bottom sticker. This number will be the number you verify on your report and your transfusions tag, the blood group of the unit, and the expiry date of the unit. So ABO blood group systems. ABO blood group system is our main category. So you can think about it like the most important and the most basic way to categorize blood. So we sort people into 4 big groups: Group O, Group A, Group B, and Group AB. Each group is based on the antigens on the surface of the red blood cell. So you can see above that Group A has A antigens on the red cell surface and anti-B antibodies in the plasma. Whereas Group O has no antigens on the red cell surface, but has anti-A and anti-B in the plasma. So why is this important? If you give a Group O person a Group A donor unit of red blood cells, the anti-A that is naturally occurring in the Group O patient's plasma will bind to the donor cell and cause the donor cell units to hemolyze. But ABO is not the only complexity when it comes to blood compatibility. There are subcategory blood group systems. So there are over 30 blood group systems that we test for in transfusion medicine. So just because a person is O positive, It does not mean that any unit of O positive blood is compatible. Patients develop antibodies to these other blood group systems by transfusion of donor red cells, pregnancy, and sometimes they are naturally occurring. So sometimes it's just easier to understand when you see it a different way. So here's a couple different depictions of basic compatibility charts. So if a patient has a negative antibody screen, meaning we aren't detecting any of those other 30 blood group systems antibodies in their plasma, these are the units that they would be compatible with. So you can see that O positive can receive O positive or O negative, but O negative can only receive O negative. A patient who is AB positive, however, can receive all blood types. This is why O negative is the universal red cell donor and AB positive is the universal red cell recipient. O positive is the most prevalent blood group in our Canadian demographic, followed by A positive. Here's just another diagram to show basic compatibility if a patient's antibody screen is negative. I've said that O negative is the universal donor, but some smaller sites keep only O positive on hand as their unmatched blood. Why? First of all, O negative is in high demand, so we don't want to deplete the country's stock by unnecessarily transfusing it or outdating it. Only 7% of the population is ORH negative, so we need to save it for those patients that truly need it. Patients who can only receive Rh negative are patients who are Rh negative, patients with an anti-D, women of childbearing age receiving unmatched blood, and pediatrics, which is defined as less than 17 years, receiving unmatched blood. Secondly, O positive is safe for most emergency unmatched situations. If we give an O positive unit to someone who's Rh negative, they will not hemolyze like they would if a group A unit was given to an group O person. This is because people don't naturally have anti-D in their plasma. Anti-D is the antibody against Rh positive blood. Provincially in Saskatchewan, we now give O positive as unmatched to males greater than 17 years and females greater than 45. What can happen if a patient receives Rh positive blood and they are Rh negative is they may develop an anti-D later on, meaning they would no longer be able to receive Rh positive blood in the future, and this antibody can also cause serious problems in pregnancy. It's called hemolytic disease in the newborn. D. Anti-D is not naturally occurring and can only be developed when an Rh negative patient is exposed to Rh positive blood. This can only happen through pregnancy and through a red blood cell transfusion. So why is developing an anti-D a problem? So it causes hemolytic disease of the fetal newborn in subsequent pregnancies. So this is why we give Winrow to Rh negative mothers, and it's so important to prevent the development of an anti-D. And it can complicate future red blood cell transfusions. That being said, just because a patient is Rh negative and they receive Rh positive blood, it doesn't mean that they will definitely develop an anti-D. Whether someone forms antibodies depends on their immune system. Some people are just more immunogenic than others. However, there is always a real possibility that an anti-D could develop, and if it does, it can create complications in the future transfusions and future pregnancies. This is why we avoid giving unmatched blood unless it's truly a life or death emergency. In those critical moments, saving the patient's life takes priority, but the long-term risks still matter once the immediate crisis has passed. Transfusions in Canada are extremely safe, largely because Health Canada holds us to such high standards. The statistics on this slide show the chances of contracting disease through transfusions are incredibly low. But the number I want to draw your attention to is the risk of giving a patient an ABO incompatible unit is about 1 in 350,000. So that might seem rare, but it's actually quite high when you consider that 1 unit incompatible red cells can be fatal, and that the main cause of ABO incompatible transfusions is patient identification errors. So these can happen at any step, during collection, by the phlebotomist, during testing in the lab, issuing the unit, or at bedside when the unit is being hung. So this is exactly why we have such a strict policy requiring 2 nurse patient identification and proper bedside checks. It's also why transfusion samples across the province require a second independently collected sample for a confirmatory blood grouping. I'll talk about that later. A simple demographic mismatch can be deadly, and a risk of 1 in 350,000 is still far too common for something that is human error and completely preventable. Patient identification before sample collection. Positive patient identification must be performed before collecting any pre-transfusion samples. Canadian standards require that the patient must be identified using at least 2 unique identifiers. Identifiers include first and last name, HSN, MRN, or other unique identifier, and a date of birth if required. Some sites require the date of birth as per local policy because it is best practice, so find out if the date of birth is required in your site. For specimens collected without the use of an electronic identification system, so Regina has a scanner that they use as a second identifier. Obviously, all of our smaller sites do not have that electronic identification system. So in other sites without that, a 2-person patient identity verification must be done at the patient's side before collecting the pre-transfusion samples. Both individuals performing identification must sign the requisition, and this may be the patient and the healthcare provider or 2 healthcare providers. If the patient can't identify themselves, a caregiver or a family member or another qualified healthcare provider can confirm the patient's identity. If any identifier does not match, do not collect the sample until the discrepancy is resolved. Sample requirements. It's important to note that cross-match, group and antibody screen, and type and screen are all synonyms. When doing a blood group and antibody screen to be tested on site, use the local requisition and check off group and screen. The sample requirements for group and screen are 2 EDTA purple top tubes. A cross-match is valid for 14 days if a patient has not been transfused red blood cells or pregnant in the last 3 months. If a patient has been transfused red blood cells or pregnant in the last 3 months, their cross-match is only good for 4 days from the time of collection. As we talked about before, both red blood cell transfusion and pregnancy can stimulate the immune system, and the patient may develop an antibody. Hence why we do not transfuse a red blood cell without a current antibody screen. Without the appropriate testing, transfusing a patient that has developed an antibody can cause a serious transfusion reaction. The labeling requirements for a group and screen are the full first and last name, HSN or MRN, a date of birth. Date of birth is best practice and a requirement in most Southern Sask facilities. Initials of the collector, and the TSIN. The TSIN stickers are a unique set of numbers that can only be used once for a single sample collection. The TSIN sticker must be placed on the patient's armband, and the armband must stay on the patient from the time of collection to completion of the transfusion. The sticker links that group and screen sample to the patient's arm and the cross-match testing done to that specific sample. Sample requirements when referring testing to Regina. If a patient has a positive antibody screen or requires blood with a specific attribute, the sample must be sent to Regina for complex testing. The sample requirements for a group and screen are 3 EDTA tubes. Please note that if a patient has an antibody, we need lots of sample to do the antibody ID, so please always try to send full tubes so there is no delay and we don't have to wait for more sample in Regina. This is the requisition you will use when referring the testing to Regina. The requisition can be found on the SAS Blood website under the Forms tab. Check off antibody type and screen. If you are requiring blood sent back out to your site, please always call Regina and let them know that you're sending a sample and expecting units back out. If Regina does not ask, please ask if the patient requires a confirmatory blood group. The sampling requirements are the same for all transfusion samples. A full first and last name, HSN or MRN, date of birth, the initials of a collector, and the TSIN. And again, the TSIN stickers are unique, and each set of numbers can only be used once for a single sample collection, and they can never be reused. So if Estevan or Weyburn has done the testing and the antibody screen has come up positive and more sample is being collected to send to Regina, a new TSIN must be used for that collection. The TSIN sticker must be placed on the patient's armband and the collector's initials must be on the tube. The requisition must be signed and dated by the collector and the person who identified the patient, the second person who identified the patient. If any information is missing or illegible, the sample will be rejected and will need to be recollected. There are no exceptions when it comes to transfusion samples. Confirmatory blood group is collected to reduce the risk of ABO mistransfusion in patients who do not have a historic blood group or transfusion record on file. If a patient has a historical blood group on file from anywhere in Saskatchewan, this can be looked up on the eHealth viewer, and a confirmatory blood group does not need to be collected. Without a second independently collected sample, errors such as misidentification at the time of collection could go undetected and lead to the wrong blood type being transfused. We understand that it is not always feasible in a small center to have a second person do the confirmatory collection. In that case, if you do not have a second person available, the same person must leave the room, come back, re-identify the patient, and collect a second time. We understand that it seems silly. Unfortunately, it is a transfusion standard that no one is exempt from. Its purpose is to ensure that the right blood goes to the right patient, and it provides a second identity check that prevents the patients from the most preventable and most dangerous transfusion-related errors. At the end of the day, it's all about patient safety. For testing sites, use your local requisition and check off ABO and RH. Only one EDTA lavender tube is required for a confirmatory blood group, and the labeling requirements are the same for all transfusion samples with the exception of the red TSIN sticker. As we said before, the TSIN sticker is attached to the antibody screen, not to the blood group. There's tons of SAS Blood resources on our website, so you could make yourself familiar with the website would be beneficial for your site. Deciding when a patient should be transfused is the physician's responsibility. That decision should be based on the patient's overall clinical status. So things like hemodynamic stability, evidence of active bleeding, and signs and symptoms of inadequate oxygen delivery, not just the hemoglobin level alone. It is also the physician's responsibility to determine how urgent the situation is, not the nurse and not the lab, including whether the sample needs to be sent stat by cab to Regina or if it can safely wait for the routine courier for transport. There are many resources available on SAS Blood website, both for physicians and for your team. This includes the general red blood cell transfusion guidelines. As a general rule, a hemoglobin less than 60 is considered critical. There are very few clinical situations where a patient would not be transfused at that level. A critical hemoglobin result should prompt a stat group and screen to be collected and tested to avoid any delays in transfusion. If the antibody screen is positive, the sample must be referred to the Regina General Hospital for further testing. In these situations, it is the lab's responsibility to notify the physician that compatible blood is not immediately available, and the sample will need to be referred to Regina for cross-matching, with the units being sent back to their site. A flowchart from the SAS Blood website that will help your team in their decision making. If you are ever unsure in a situation, make use of the resources available to you. You can call the Regina General Hospital Transfusion Medicine Lab and talk to them because they will be your technical experts in the area. They will talk you through what your next steps are or guide you to call the transfusion medicine physician on call for guidance. How to fill out a TM requisition. The yellow boxes must be filled out by a nurse, physician, or unit clerk based on the physician's orders. These boxes are not to be filled out by the lab personnel. Here is a properly filled out requisition. The addressograph must have all the same information as the sample labeling requirements. The physician ordering and transfusing facility with a contact number. This box gives a brief history and clinical picture of what is going on with the patient. Previous transfusions and pregnancies is in case there is a possibility the patient has developed an antibody. This information also changes the outdate of the antibody screen. The historical blood group tells us if we need a confirmatory blood group collected. Request details informs Regina of what testing to do and if you require blood products backed out to your facility. This bottom box is to be signed by the person who filled out the requisition prior to the sample being collected. This box is to be filled out by the person collecting. There must be a date and a time and 2 healthcare professional initials. The patient must be identified by 2 individuals for all transfusion samples. For a group and antibody screen, the TSIN sticker goes in the appropriate box. The referring laboratory is the middleman. If for a transfusion laboratory, write that here. If you are going to ship directly and receive from the site, it is not necessary to write that twice. If you require blood to be sent out to your facility, someone must call RGH Transfusions at this number. Acceptable versus unacceptable. I have some examples here of acceptable versus unacceptable. So here's the first example. This sample is illegible and will be rejected. Here's the second sample. This sample is also unacceptable because there is no date of birth on the tube. Unacceptable because the first name and the date of birth are incorrect and there's no TSIN sticker. This is unacceptable because there is no TSIN. It would, however, be acceptable for a blood group only confirmatory sample. This is the type of sample that we get rejected the most from the rural sites. I know that we know our patients and we just collect them and take it back to the lab and there's only one of them, but it is not acceptable to not have all the full name, date of birth, and HSN and TSIN on the sample from bedside. So samples must be completely labeled at bedside. So if you need to take a label with you, a blank label, and write on the label because you don't feel like you can fit it all on the tube, that is acceptable, but the underlabeling is not acceptable. This is a properly labeled sample. So just a reminder, for an acceptable labeling requirements is the full first and last name, the HSN or MRN, the date of birth, the TSIN, and the initials of the collector on the tube. Remember that transfusion samples can never be relabeled or have missing information. Any sample that is illegible or mislabeled will be rejected and will need to be recollected. In the blood boxes, the credo coolers. So samples that are sent to Regina by courier or cab will have units sent back with the courier or by cab in these credo coolers. If a sample and or blood needs to be sent stat, it will have to be approved by the Regina hematopathologist on call. The credo coolers will come to you packed with a safety seal like this. And the credo coolers are validated to keep packed red blood cells between 1 and 6 degrees. Credo cooler will look like. RGH has validated the credo coolers to transport a maximum of 3 red blood cells. The credos will have all the necessary paperwork inside. On the top of the cooler, you'll find a green sheet of paper. This sheet indicates the date and time the blood unit is valid until inside the sealed cooler. If the date and time is beyond the time written on the green paper, call the Regina Transfusion Medicine Lab for guidance. Inside the credo coolers. Inside the box will be all the necessary paperwork you need to issue and transfuse the blood inside. Inside the box is a patient blood bank report form for the testing done in Regina, the SHA blood products issue voucher for rural facilities form, and a notification of administration of blood and or blood products form. This is the product issue voucher form. The top area will be filled out by the Regina TML. This yellow portion must be filled out by the lab when putting the units into inventory. The 3 boxes must be checked off. The tamper-proof tie on the shipping container was intact. The blood for transfusion passed the visual inspection, and check that they checked for the blood bank report. This pink box will need to be filled out by the healthcare provider transfusing the unit. Signature, date, and time the box was open, and signature, date, and time the unit was hung. Please note this information also needs to be written on the transfusion administration record, or the TAR. All of this must be filled out and faxed back to RGH. A photocopy of the form and apply it to the patient's chart, and send the original back in the Credo to Regina. The RGH fax numbers are on these forms. This is the patient notification form. This form stays on the patient's chart until discharge, and at discharge, the patient must sign that they have been notified that they have received human blood products or components during this stay. The form does not need to be faxed back to the lab or to RGH. This form was put in place in response to the 1993 Crever Commission for patients who did not know that they were transfused and received blood products in hospital and were infected with HIV and hepatitis C. Blood administration. Upon hire, all staff participating in transfusions must complete the administration of blood components and blood products Module 1 and Module 2. The administration of blood components and blood products Module 2 and the handling and transporting of blood must also be done annually. For every transfusion of blood components or blood products, a transfusion administration record, a TAR, is required. The TAR must be filled out at the time of transfusion. Prior to picking up blood products from the lab, please ensure that you have completed and have documentation of all of the following. Informed consent. Patient identification is attached to the patient. Written physician transfusion order. Blood group and antibody screen has been completed and you have the report. Dedicated IV line access and baseline vitals have been completed and documented within 30 minutes of the transfusion. We know in smaller centers, the patients are not always wearing their identification armbands, but if you are transfusing blood or components or blood products, it is mandatory that the patient be wearing the patient identification armband regardless of the site you are transfusing in. Prior to infusing, informed consent for the transfusion must be obtained. It is not the responsibility of the nurse to obtain consent. It is the responsibility of the physician or the nurse practitioner. It is their responsibility to make sure that the patient is aware of the material risks, nature and consequences, benefits, and the person must also be made aware of reasonable alternatives, including the consequences of refusing blood products and components. These risks include the fact that any blood product or component obtained from human sources may contain unknown agents that may transmit disease. The discussion must be documented on the informed consent form. It is the nurse or the transfusionist's responsibility to ensure that the consent is on the chart and signed prior to hanging the unit. Consent must be obtained once per hospital stay, except for in treatments like IVIG, where the consent is only required once per year, as long as the diagnosis and treatment plan have remained the same. This link can be found on the Blood Administration Clinical Standard, and it is a great resource for patients and families who have any questions about blood transfusions. This is a picture of the new provincial informed consent form. It will be replacing all former health region consent forms that are floating around out there. It is set to be rolled out in the summer of 2026. Picking up blood products from the lab. A transfusion pickup slip is always required when picking up any product or component from the lab. This slip can be a requisition or a piece of paper with the appropriate information on it. There's going to be a provincial transfusion request pickup slip document created at some point, but we don't have a date on that yet. The slip must contain the recipient's first and last name, date of birth, and a unique identifier such as the HSN, the recipient's location, the component or product type requested, the volume, quantity, or dose required. These pickup slips must be retained for 5 years. A visual inspection of the component or product must be performed by the technologist prior to issuing. The technologist and staff picking up the product or component must confirm that all the patient identification from the request slip matches the component or product and the component or product matches the tag. This can be done by one person reading off the logbook and the other person following on the unit and tag. Issue of the component or product must be documented in the transfusion logbook. The logbook must be signed by the technologist and the staff picking up the product. By signing the logbook, you are taking responsibility that you have completed all these steps. After hours, 2 healthcare providers must complete the previous steps prior to the component or blood product leaving the lab. Bedside pre-transfusion checks must be done at the bedside in the presence of the patient. Checks must be done and documented on the TAR by 2 qualified healthcare professionals. Patient must verbally confirm their identity. If the patient is nonverbal, a family member or another healthcare provider can do this step. Patient identifiers must be identical on the blood bank report, patient armband, and the component or product tag. Confirm that the correct patient ID is at the top of the transfusion administration record form. And if transfusing a component, you must verify the ABO and RH compatibility by referring to the blood bank report. Confirm all the unit or lot numbers match on the unit or vial to the transfusion's tag. Perform a visual inspection and confirm the expiry date. Each healthcare provider must sign the TAR. If there are any discrepancies, do not transfuse. Call the laboratory or the tech on call and return the unit to the lab immediately. If the pack cell was from Regina, call Regina TML at this phone number. Administration record, the TAR. After completing all your pre-transfusion checks, attach the pink copy or the duplicate copy of the transfusion tag to the TAR. The example on this TAR is the tag that you will receive from the RGH. This is an example of what the new tags that will be issued in Weyburn and Estevan and Weyburn. There's a sticky strip on the back of the top copy to affix to the TAR, and the white carbon copy on the bottom is to remain attached through. A copy of the transfusion tag must be attached to the unit for the entire transfusion. This is what the TAR looks like, and it can be found on the SHA website under Clinical Forms and Catalog, or on the SAS Blood website under the Forms tab. It is the responsibility of the healthcare provider transfusing to confirm that the appropriate patient information is at the top of both pages of the TAR. Here's an example of a properly and complete filled out transfusion administration record, or TAR. As you can see, the patient identification is in the top right corner of both sheets. There are initials in all the appropriate boxes of who completed those tasks. There are 2 healthcare professionals' signatures and initials in the bedside pre-transfusion independent double check box. And on the second page, the type of product or component transfused and the unit number or lot number and the ABO is all complete. The start of the transfusion and the finish time of the transfusion is complete, and all the appropriate vital documentation as per the clinical standards are filled out and initialed by who completed it. On the bottom of the second page, you can see the new transfusion record tag. that will be used in your facilities. It has a sticky strip on the back of the pink and top copy that it makes it easy to affix it to the bottom of the tar. Blood component and product monographs. What are they and where to find them? The product monographs have all the information that you could possibly need to know about each product or component, from the description to indications to dosage to administration to adverse events. Where can they be found? They can be found on the SAS Blood website. Under each product or component, there's a link to the monograph, or on the SHA website, you can search transfusion medicine and it'll take you to this page, and or search blood or product monograph and resources. Patient monitoring. Transfusion of blood components must be completed within 4 hours from time of removal from a temperature-controlled environment. Therefore, they must be infused within 4 hours of opening the Credo or 4 hours from time of issue in the lab. Standards say that you have 60 minutes to spike the unit once it leaves cold storage, but you have to remember that now you only have 3 hours to transfuse that unit. So be mindful, and it is always our suggestion not to open the cooler or go pick up the unit until you are ready to transfuse. Administration of blood products such as albumin must be completed within 4 hours of accessing the product vial. If 4 hours has elapsed and the transfusion is not complete, the transfusion must be discontinued and the remaining blood component or blood products must be discarded. We always start our infusion slowly for the first 15 minutes, so 50 mils per hour, and then increase as tolerated to the MRP ordered infusion rate. All patients should have their vital signs checked within 30 minutes prior to initiating the transfusion, 15 minutes after blood exposure. So the 15 minutes that we're starting slowly infusing shouldn't start until there's actual blood exposure. So don't start that 15 minutes at a slower rate until when the line is still priming. Every 60 minutes until the transfusion is complete, within 15 to 30 minutes after completing the transfusion, or as clinically indicated if there is some sort of symptom or a reaction. All this being said, there is still always a chance of a delayed transfusion reaction, so we want to make sure that our patients or anybody who is taking over our patients are aware that there are signs and symptoms to be watching for the next several hours. Post-transfusion, flush the tubing with normal saline to clear the line or between consecutive units, disconnect the infusion set and discard. Plug the open port on the blood bag to prevent leaking. Document the completion of the transfusion on the tar. Do not discard the transfused blood bag. It is important to keep the unit for 12 hours post-transfusion in the event of a delayed transfusion reaction. Place the red blood cell unit bag in a bag and place it back in the Credo with the original issue voucher form and send it back to Regina. Transfusion reactions. Report everything. Transfusion reactions across Canada are wildly underreported. Why? Mainly because most transfusion reactions look like other common clinical issues. Symptoms such as fever, hypotension, tachycardia, respiratory distress, nausea, rigors, rash can all be attributed to many disease states. There are lots of gaps in education or inconsistent training. Staff may be unaware of what qualifies as a reportable reaction or believe only serious or obvious reactions need to be reported. They may underestimate mild or delayed reactions such as taco or a mild allergic reaction. Delayed and subtle reactions are often easily missed. Maybe they don't transfuse often enough to see the symptoms. Reporting feels time consuming. They have fear of blame or consequence that they did something wrong, or the belief that the patient is fine, so it does not matter. Please report everything. Algorithm will be on the back side of the issue voucher in the Credo cooler, and it can also be found on SHA's website under Blood Administration Resources, Clinical Resources. There's also many more resources on the SAS Blood website under Transfusion Adverse Events page. Signs and symptoms of transfusion reactions. Fever, mild reactions include fever and chills greater than 1 degree of a temperature or a temperature greater than 38. Also, the feeling of being cold or chills should be monitored for up to 4 hours post-transfusion. Skin reactions, allergic symptoms, restlessness and anxiety. This is one that gets missed a lot. If a patient has a general feeling that something is wrong, stop the transfusion. It is commonly missed just because people don't believe the patient, but the patient knows if something is wrong. Headaches, those are often associated with IVIG. More severe reactions, breathing problems, pain, gastrointestinal distress, cardiovascular issues. Some less common but very serious signs are changes in urine. Darker reddish urine can mean hemolysis, bleeding, abnormal or heavy bleeding from the IV site or elsewhere, or neurological changes, dizziness, restlessness, confusion, are all transfusion reaction symptoms. If you have a transfusion reaction, what do? Stop the transfusion immediately. Start a new line of saline and keep the vein open. Take vital signs, including temperature. Ensure the patient is comfortable and start oxygen if required. Recheck the patient ID and blood product. This is probably missed most often. Notify the ordering physician and the transfusion medicine department. Do not continue the transfusion or disconnect the unit unless directed. It is the responsibility of the physician to decide if it is an adverse event. The physician may direct you to continue the transfusion after administering medications such as Tylenol or Benadryl. This is okay, but the reaction is still reportable. So if you stopped, treated, and finished the transfusion, the reaction can still be reported on a TARE form. If the reaction is severe, always call the TMP on call. Administer the drugs as ordered. Complete the Saskatchewan Transfusion Adverse Events Report Form, the TARE form, not to be confused with the TAR. This form can be found on the SHA website, on the Transfusion Medicine homepage, or on the SAS Blood website under Forms. You must collect a post-transfusion reaction sample. It will be 2 lavender EDTA tubes, and they must be labeled the same as a regular transfusion sample. For transfusion reactions in non-testing sites, you send everything to Regina General Transfusions Department. Page 1 of the TARE form, the blood component, unit, or product vial, the post-transfusion sample, and the nursing notes from the transfusion. SAS TARE form. It is 3 pages long. This is the first page, and the healthcare provider completing the transfusion is responsible for completing every section of the first page and putting the patient's addressograph on all 3 pages before sending it to the lab. Testing facilities are responsible for filling out this section on the second page after testing is complete. After testing is complete, send all the paperwork and nursing notes to RGH for the hematopathologist to review. The non-SoftBank disposition and utilization form. This process went live November 17, 2025, and all non-SoftBank sites are required to use this form. A form should be filled out and faxed to Regina for all blood components and products issued to patients at your facility. This process ensures that all transfused components and products are visible on the eHealth viewer, which supports continuity of care for patients across Saskatchewan. When you're filling out the form, please ensure that all of Section A is complete and legible, and there is patient identification on both pages. Section B will be filled out by the Regina TML. SHA blood issue and administration audit. I'm going to start by saying that this audit is lab and nursing's responsibility. The process went live on February 15, 2026, and the bedside audits are used to strengthen patient safety and make sure that we're consistently following best practices when issuing and administering blood products. It is a national accreditation standard, and was designed to help identify any gaps in practice and reduce the risk of transfusion errors. Overall, the process supports safer and higher quality of care for our patients. All of our auditors will be required to complete the learning module on My Connection. I've put in here the audit requirements based on transfusions per year for each of the sites in former Sun Country. Prov 342, the Blood Issue and Administration Audit, can be found on the SHA website under the Transfusion Medicine page or on the SAS Blood website. The audit form is filled out by the auditor, and the auditor can be an MLT, a CLXT, a CNE, or a nurse that is not involved in the patient's care. The original memo says that the nurse must be from another unit, but we found that some smaller sites have told us that this just isn't always feasible. So we have decided to change it to it's as long as the nurse is not directly involved in the patient's care or the transfusion, they can complete the audit. The purpose of these audits is not meant to be disciplinary. It's to show gaps in practice and education. And if someone on your site is making an error or has a question, probably somebody on another site is having the same question. So we just want to make sure that we are giving everybody all the tools that they need to be able to transfuse safely across the province. The SHA Integrated Service Area Transfusion Utilization and Safety Interdisciplinary Committee, or the ISA South Rural TUSIC. What is the ISA TUSIC? It is a multidisciplinary transfusion committee required under accreditation standards. It brings together physicians, nurses, and laboratory staff and leadership to oversee and support safe, appropriate, and effective transfusion practices within the integrated service area. Why we need it. The committee ensures high quality patient care by promoting best practices in transfusion medicine and patient blood management, auditing how blood components and products are used, reviewing transfusion reactions and errors, and implementing corrective actions. It also shares and develops policies, educational materials, and supports alternative to transfusion, and serves the local emergency blood management committee during the blood shortages. This structure ensures accountability, consistent standards, and clear communication across the province. This committee is not optional. It is an accreditation requirement, and several of our rural sites are now being cited for not having active physician participation. If we cannot secure volunteers from your facilities, we risk losing the ability to transfuse blood in our smaller centers, which means that patients will need to travel farther from their homes for care. So your participation is directly protecting your local access to safe transfusion services. We are still looking for a physician lead for the South Rural ISA TUSIC. So if you know anybody, please send them my way.